Thank you, and thank you all for joining us. My name is Sarah Brinkman. I'm a program manager with the Lake Superior Quality Innovation Network, which serves Michigan, Minnesota, and Wisconsin. And today, my colleague Ross Gatsky and I will be walking you through an overview of the current status and program specifications for the Hospital Value-Based Purchasing Program, Hospital Readmissions Reduction Program, and the Hospital Acquired Condition Reduction Program. We'll share tools and resources available to assist in your understanding of these programs, as well as some strategies for quality improvement. We'll be opening up the lines for questions at the end of the call, but encourage you to use the chat box throughout, and ask that you please note that near the end of the call, an evaluation will appear on the right-hand side of your screen. We greatly appreciate your feedback and ask that you please take a few moments to complete that before logging out of the webinar today. The programs that we're going to be talking about today, and in some cases the measures that make up the programs, have different performance or encounter periods. And so we'll be referring to them in the way that the Centers for Medicare and Medicaid Services refer to them, which is to refer to the payment period or the fiscal year. So we'll talk about the performance periods in some cases. There's always followed by a reporting period, and then the payment period or fiscal year are the years that we'll be talking about with regards to the program. Much of the information we'll review today can be found on our Quality Reporting Program fact sheets, which are available on the Lake Superior Quinn webpage. There is a link there on this slide, and I believe that we'll be posting a link to that in the chat box as well. These fact sheets were just recently updated, so we encourage you to please take a look at them. They do provide some basic information and background of the programs in question, and they also focus on the technical aspects such as eligibility, scoring, and performance periods. So to kick things off, we're going to jump in by looking first at the Hospital Value-Based Purchasing Program. This program started in October of 2012, and it is only applicable to inpatient prospective payment system hospitals. There are 4 domains that are made up of measures. There are 21 measures in fiscal year 2019. The 4 domains are clinical care, person and community engagement, safety, and cost efficiency and cost reduction. In each of these, all the domains are made up of one or more measures, and for each measure, hospitals receive an achievement score, which compares performance to other hospitals, and an improvement score, which compares a hospital against itself in previous performance period. The higher of these 2 scores is used for each measure, and in the person and community engagement domain, there is a third scoring component based on consistency, through which high-performing hospitals can earn up to 20 additional points. Scores for measures are rolled up to a domain score, and those domain scores are then weighted and added together to establish a total performance score, which is the ultimate score for the program. The total performance scores are then evaluated, and incentive payments are determined utilizing a linear exchange function, and hospitals risk losing up to 2% of their diagnosis-related group or DRG reimbursement, and the pool of penalty funds from low-performing hospitals is used for the incentive payments of the high-performing hospitals. In the scoring methodology, I referenced domain weighting, and starting in fiscal year 2018 through at least fiscal year 2023, the 4 domains are weighted at 25% each, and they are shown here, and this graphic will become familiar to you if you look over the fact sheet for the value-based purchasing program that we referenced earlier. These are the domains and the measures that make up the fiscal year 2019 and fiscal year 2020 value-based purchasing program years. The measures are slated to be the same in both years forthcoming. In clinical care, there are 3 30-day mortality measures, as well as a new complication measure for total hip and total knee arthroplasty. From the person and community engagement domain, the measures are comprised completely of the measures through the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAP. In the safety domain, there are the healthcare-associated infection measures, which are reported through the National Healthcare Safety Network through the Centers for Disease Control and Prevention, including the central line-associated bloodstream infections, the catheter-associated urinary tract infections, surgical site infections, both colon and abdominal, hysterectomy, MRSA, and C. difficile. And then there is the perinatal measure, which is the early elective delivery measure. You might note that the Patient Safety Indicator measure, FY20 has been removed from the program in fiscal years 2019 and 2020. We'll talk about that a bit about future measurements in a few slides. The final domain is the efficiency and cost reduction domain, and that is currently comprised of one measure, the Medicare spending per beneficiary measure. Additional measures are slated to be added in future years, and I'll talk about that in a moment. So in addition to the general requirement of being an inpatient prospective payment systems hospital, there are eligibility requirements relating to the scoring for each of the domains in value-based purchasing. In order to receive a total performance score, a hospital must get a score in at least 3 of the 4 domains. And then this chart lays out the requirements to receive a score in each of those domains. So in clinical care, a hospital must have at least 2 of the scores for at least 2 of the measures. And each of the measures requires a minimum of 25 cases in order to receive a score. In person and community engagement, the hospital must have a minimum of 100 HCAP surveys completed during the performance period. In the safety domain, they must have a score for at least 3 of the measures. In the case of the elective delivery measure, they require at least 10 cases. And for the healthcare-associated infections that are reported to NHSN, they must have at least 1 predicted infection during the applicable period in order to have a standardized infection ratio calculated for that measure. Finally, in the efficiency and cost reduction domain for Medicare spending per beneficiary, they must have a minimum of 25 cases to receive a score for that particular measure. So we're just going to take a few moments here to review across our 3 states. Again, we're representing Michigan, Minnesota, and Wisconsin, how hospitals performed in the value-based purchasing program from fiscal year 2018. So as we look at the total performance score across the 3 states and then compared to the nation, you can see that all 3 of our states performed better than the national average. And what we see here is that Minnesota scored close to 50 on average for the total performance score. Wisconsin was somewhere around 45, and Michigan was somewhere around 40, where the national average appears to be somewhere in that 38-ish range as far as average score. We thought it was interesting to take a look at how each of our states fared with regards to the domain scores, in part because we really wanted to highlight the importance of collaboration across our 3-state region in identifying opportunities for improvement as well as strategies for improvement and peer sharing across hospitals across our 3 states. So as we look at the clinical care domain score, Michigan had the highest average score. Minnesota was very close second, and then Wisconsin was not far behind as well. But we can see that Michigan was the highest performer for the clinical domain area. And then we can see that things flip when we look at patient experience, the patient experience domain. So when we look at this particular score, which is also called the person and community engagement, it's changed names numerous times over the years, but in 2018 it was the patient experience. And so Wisconsin came in at somewhere between 13 and 14 points on average, Minnesota somewhere between around 11 points, and then Michigan somewhere around 9 points on average. So we can see that we have some learning to do from the Wisconsin experience with regards to this particular domain in the HCAP scores. When we look at the average safety domain score, we can see that Minnesota has the highest score across the region. So you can kind of see the trend here. We're bopping around, and we all have something to learn from one another, which we thought was the value of sharing these particular slides with you all. Unfortunately, when it comes to the domains, we do not yet have average scores nationally. We only have the average total performance score. So we're not able to see how we compare to the national average for each of these. And finally, we have the final domain, which is the efficiency and cost reduction. So this is the Medicare spending per beneficiary measure, and Minnesota has the highest score in this area as well. We just want to take a few moments to go through some quality improvement strategies as they relate to these 4 domains. So when we think about clinical care and look at them, in particular at the mortality measures, a lot of these instances are related to end-of-life care, and therefore care planning in the community is essential for understanding patient wishes and avoiding any unwanted admissions and potential readmissions to the hospital. So that's a really important strategy to be able to improve the performance with relation to mortality, as well as to improve and be meeting what your patient wishes are. Early identification and treatment of sepsis remains critically important. We know that that can be a major factor for these mortality measures and just patient outcomes in general. When we look at, in particular, the mortality measures, it's important to understand the differences between AMI versus the heart failure and pneumonia. For AMI, most likely this happens in the inpatient setting. But with heart failure and pneumonia, it's more likely to be more of those ongoing or chronic illnesses, and therefore opportunities exist in enhancing care transitions and the care that someone receives outside of the facility. And in our new measure, when we look at the total hip and total knee complications, there are some risk factors associated with that type of procedure, including evaluating morbid obesity, malnutrition, hyperglycemia, uncontrolled diabetes, smoking, alcohol abuse, depression, and so on. And so it's really important to implement effective screening and address patient risk factors before the surgery in order to reduce the prevalence of complications. Next, we have the quality improvement strategies for the person and community engagement domain, which again is HCAP. And this is really a way for us, for consumers to use the results in order to understand a hospital's focus on patient satisfaction. So thinking about how a patient experiences care within the facility. And what we want to really highlight is that it's important to remind employees why they got into healthcare in the first place and encourage empathy with their interaction with patients, and that's really a starting point. And from there, you can provide training and support for staff to enhance their situational awareness and recognize successes that they have in order to encourage further improvement and enhance resiliency. We want to make sure that patients are involved in providing feedback regarding their experiences or the experiences of their loved ones, as well as an opportunity to provide input into areas of focus for improvement through patient-family advisory committees. And all of these are important in ultimately creating a culture of patient safety in which staff feel supported to provide the appropriate care and patients feel confident in the care that they are receiving. Some quality improvement strategies related to safety. We know that with early elective deliveries, it's important to have clearly defined policies about such procedures and really to engage patients in early education and preterm care so that they are aware of what those policies are and so that they can make the best choices for their care. With healthcare-associated infections, there are no lack of resources out there to help support that, and the Centers for Disease Control and Prevention and the National Healthcare Safety Network websites are a great place to start. There's bundles basically developed for all of the healthcare-associated infections that are included in the value-based purchasing program, and as long as your staff are utilizing those, they've been shown to be effective. We encourage you to provide training and resources for staff to follow the protocols, follow the national testing and reporting guidelines, which can be very important in terms of being able to ensure that infections are relegated to the appropriate buckets that they get put into when you report them to the National Healthcare Safety Network. And also implementing antimicrobial or antibiotic stewardship has become a highly important topic and is definitely tied to infection prevention, specifically as we think about, in particular, the C. difficile infection. Finally, we have the quality improvement strategies for the efficiency domain, which is the Medicare spending per beneficiary measure for fiscal years 2019 and 2020. Lake Superior Quinn did a 3-part webinar series on MSPB earlier in 2017, and so we encourage you to check out those webinars if you're interested in learning more about the measure itself and hearing some more about some improvement strategies related to those. What we really walked away with from that 3-part series was that there are the 3 distinctive periods that you should be looking at. So prior to a patient's admission, it's really important to ensure that the hierarchical condition categories are being captured appropriately. And apologies for that typo there. It should be captures, not captures. And in order to be able to inform the risk adjustment for the measure, and also to ensure that patients are receiving appropriate care prior to admission. During admission, you want to consider post-acute needs and balancing those with length of stay And clinical documentation improvement has been, or CDI has been a popular topic as we were looking at Medicare spending per beneficiary and improving the scores for that. Finally, with post-admission, it's really important that you're coordinating that post-acute care with area-skilled nursing facilities, home health agencies, primary care, and other partners. A number of hospitals have developed post-acute care networks where they are working specifically with skilled nursing facilities that they partner with often, so they are confident in their performance and they're able to streamline communication and ensure that patients are getting the care that they need at that point in time. So before moving on to the other two programs that we're going to talk about today, wanted to just mention some future measures that are slated to be coming out as per the most recent final rule. In the clinical care domain, we'll be seeing two additional 30-day mortality measures. One will be coming in fiscal year 2021, and that is for chronic obstructive pulmonary disorder, or COPD. And in 2022, we'll be seeing the coronary bypass graft, artery bypass graft 30-day mortality measure added. And as I mentioned before, PSI 90 has been removed for the safety domain, at least for the time being, but it is slated to return in a new form in fiscal year 2023 under the safety domain as the patient safety and adverse events composite. And Ross will talk a bit about that when we talk about the hospital care condition reduction program. Finally, in the efficiency and cost reduction domain, for as long as value-based purchasing has been around, Medicare spending per beneficiary has been the lone measure in that domain. That's about to change. So in fiscal year 2021, we'll see the 30-day episode of care for AMI and heart failure added. And then in 2022, we'll see the 30-day episode of care for pneumonia added. And of course, we'll have more information as those changes come to light. So with that, I'm going to turn things over to Ross to review the hospital readmissions reduction program and the hospital care condition.
Yes, thank you, Sarah. As Sarah had mentioned, I will be taking us through the final two incentive programs, beginning with the hospital readmissions reduction program, or RRP for short. And Sarah, could you please pass the ball?
Sorry about that. It won't allow me to pass it to you. It went back to the WebEx host.
Okay. WebEx operator, could I...
Jennifer, are you able to pass the ball for us?
It's working for me. Okay, I apologize for that. Everybody, and as I mentioned, I will be taking us through the final incentive program.
Just 1 second, Ross. If you're advancing, we're not able to see the advancement on our end. Okay. So you'll still need Jennifer to fix that for us. Jennifer from WebEx, are you available? Jessica, would you be able to do some outreach to WebEx for us?
Yes, we are reaching out to her right now.
Thank you.
And like I said, once again, we apologize for this unfortunate technical difficulties.
Ross, if you just want to talk through your slides, you should get the advancement of them going soon.
Okay, thank you very much. So we will do the best that we can as a moment. So just basically giving an understanding of the readmissions reduction program. It was introduced in 2012 within the Payment Protection and Affordable Care Act. The RRP requires CMS to reduce payments as a form of penalty to Inpatient Prospective Payment System, or IPPS, hospitals with excessive readmissions beginning in October of 2012. The maximum penalty for hospitals is capped at 3%, and certain readmissions are excluded, such as transfers to another IPPS hospital and readmissions classified by CMS, such as those that are considered as planned readmissions, such as chemotherapy or rehabilitation. And for the purposes of the readmission reduction program, a readmission is defined as an admission to an IPPS hospital within 30 days of discharge from the same or another IPPS hospital. Admissions within 30 days to psychiatric, critical access, and children's hospitals are excluded. The performance period for each year of the IRP program applies 3 years of discharge data and the use of a minimum of 25 cases to calculate a hospital's excess readmission ratio. I now have control of the slides, so once again, everyone in attending, I apologize, but we should have everything working forward. Thank you. So the first year of the readmissions reduction program included just 3 measures, which were the acute myocardial infarction, heart failure, and pneumonia. So throughout the years, additional measures have been added to the program, and we are now currently at a total of 6. And there have not been any new measures added to RRP since the program years in fiscal year 2017. So CMS determines a hospital's performance within the readmissions reduction program and whether or not they will be penalized by calculating their excess readmission ratios for each of the program measures based on a risk-adjusted patient population. The excess readmission ratio is a way that CMS can score a hospital for each of the measures and have that comparable to other eligible hospitals throughout the country. Also, using risk adjustment methodology levels the playing field for hospitals by accounting for patient demographic characteristics such as comorbidities and patient frailty. Risk adjustment is another way of creating an apples-to-apples comparison between hospitals that serve different patients with different demographic characteristics. So the excess readmissions ratio is calculated as the ratio of predicted readmissions to expected readmissions. The predicted readmissions are the number of 30-day readmissions predicted for your hospital on the basis of your hospital's performance with its observed case mix and your hospital's estimated effect on readmissions. This rate is ultimately presented as a rate per 100 discharges by dividing the number of eligible discharges. Expected readmissions are the number of 30-day readmissions expected for your hospital on the basis of average hospital performance with your hospital's case mix and the average hospital effect. And a ratio over 1.0, a ratio less than 1.0 indicates better hospital performance. There were some important updates to the readmissions reduction program that were confirmed in this previous IPPS final rule, which was the fiscal year of 2018, which was released in August of 2017. So beginning with the fiscal year 2018 readmissions reduction program, which was the most previous year of the program, the extraordinary circumstance exception, or ECE for short, was updated. The ECE is a policy that allows hospitals to be granted an exception or exemption from various quality reporting requirements due to extraordinary circumstances beyond the control of the facility. This policy was updated for the fiscal year 2018 readmissions reduction program to allow for facilities to submit a form signed either by the facility's CEO or another designated personnel. The facility will be notified of CMS's decision within 90 days upon receipt of the facility's request, and also CMS will be allowed to grant the authority to grant ECEs due to CMS data system issues, which can affect data submission. Also, excess readmissions and the payment adjustments will be calculated using the 3-year time period from July 1st, 2013 through June 30th, 2016, and finally, the payments for each of the applicable conditions in the readmissions reduction program will now be aggregated moving forward. Beginning with the fiscal year 2019 readmissions reduction program, which begins in the calendar year of 2018, CMS has made some changes to the payment adjustment factor in accordance with this new law, which is the 21st Century Cures Act. This piece of legislation was signed into law in December of 2016 with the intention to level the playing field between hospitals that serve different patient populations. So what the Cures Act does is it requires that CMS account for patient demographics when calculating reductions in its payments to hospitals, and it does this by determining the proportion of a hospital's patients that identify as dual eligible beneficiaries or those patients that could qualify for both Medicare and Medicaid services. So to determine for the readmission reduction performance, the Cures Act also assigns hospitals to groups that allow for comparisons within those particular groups rather than all the hospitals across the board. And this is designed to ensure that hospitals serving patients that are of the most need, those that live in more impoverished areas or are disadvantaged, hospitals that serve that patient population are not unduly penalized. And finally, there was an adjustment to the payment methodology, which we will discuss in the next slide, and I apologize. So this slide displays the new adjustment to the payment methodology for the readmissions reduction program by assigning eligible hospitals to one of 5 peer groups, as they call them. And this was introduced by the Cures Act, and it can be complicated, but I think the important takeaway is that each of the hospitals' median excess readmission rate is now calculated depending on which peer group they fall into, rather than all the hospitals across the board. And this directly affects the payment adjustment. So these next 3 slides now show patient volumes for each of the 6 measures within the readmissions reduction program by each of the 3 states in the Lake Superior Quality Innovation Network region over the past 4 years of the program. So very briefly, here is Michigan's patient volume for the RRP program. Here is Minnesota's. And obviously, if you look at the number of the cases, they're going to be varied between the states due to just a number of beneficiaries of each state. And finally, here is Wisconsin's. And I think the most important thing to note is that consistently pneumonia and heart failure comprise of the most cases across the region, whereas coronary artery bypass grafting or CABG cases are by far the least amount, as many of the hospitals in the region don't even have enough cases or eligible discharges, which is 25, to qualify for the reporting of CABG cases within the readmissions reduction program. And these next 3 slides display, once again by states, the number of hospitals and percentage of total hospitals in each state that had excess readmissions for each of these 6 readmission reduction program measures over the last 4 years of the program. So beginning with Michigan, here's the excess readmissions for Michigan. And here are those for Minnesota. And finally, Wisconsin. And once again, we will have, you guys can have access to the slides. We will have those available in about a week or so you can look at these graphs a little more carefully. But if you do have a chance to look at these more carefully, you might see that the hospitals had excess readmissions the most for hip and knee cases. And also pneumonia was the second most for both Michigan and Minnesota, while COPD was the second most for Wisconsin hospitals. And the overall readmission rate for hip and knee is very low. It's around 4%. So that probably explains why it's the most common condition that has excess readmissions, just due to the fact that with a readmission rate that low and the threshold being that low, it can be very challenging for hospitals to achieve a readmission rate about under 4%. Now, with the focus being on reducing readmissions, obviously there are many improvement opportunities. Readmissions tend to be a key focus for many hospitals, so we will only be able to present a handful of the available improvement strategies here, but we'll do our best to kind of summarize some of the more popular strategies. And the first, directly being tied to improving your readmission reduction program performance, you can do this by reviewing and analyzing the results from your RRP hospital-specific report that is provided each summer by CMS through QualityNet. These reports are really helpful in that they provide a detailed breakdown of your hospital's performance for each of the RRP measures, as well as a list of all patients that are eligible for discharge, their demographics, and whether or not they had an unplanned readmission. So once again, very basically, using this report can help you identify target areas for improvement on each of the 6 RRP measures. Another strategy is you can implement some of the evidence-based readmission strategies and tools into your practice. Toolkits such as Project RED, which is short for Re-Engineer Discharge, and the RARE campaign, which is short for Reducing Avoidable Readmissions Effectively. Both of these resources, these toolkits, can provide you with guidance and helpful resources to reduce readmissions at your hospital. Furthermore, working closely with social worker and nurse case managers can also reduce avoidable readmissions. Case management play a vital role in assessing the health situation of each patient, doing certain things like planning for and coordinating the next steps for the patient, and really facilitating the patient throughout the care continuum upon discharge. So really working in concert with these staff can help you optimize patient outcomes. And the last 2 bullets kind of go hand in hand in that developing strong relationships with the services and providers that your patients are discharged to will improve the discharge instruction communication. Really finding out which post-acute providers or services that are taking a majority of your patients upon discharge, and working and putting forth the effort to develop a rapport and a communication pipeline with staff from those organizations can really help you improve the whole discharge process. So a better referral process, more communication, and stronger relationships with these post-acute providers can all have beneficial impact on your discharge patients. And like I said, these are just a few suggestions amongst many in terms of quality improvement strategies to reduce readmissions. And in case you are interested in focusing on readmission work, we do have a care transition collaborative in each of the 3 states that has a specific focus on coordination of care and reducing readmissions. So if you are interested, please reach out to one of the respective contacts in each state. And finally, we will move on to the third of the incentive programs, which is the Hospital-Acquired Condition Reduction Program, or HAC for short. And as I mentioned, the HAC program is the third CMS program. It is implemented after the Value-Based Purchasing Program and the Readmission Reduction Program. The measures within the HAC program are all inpatient quality reporting measures with some overlap with the VBP program. And similar to the VBP program, the total HAC score is determined by calculating domain scores and then weighting those 2 domains. It is a penalty program as there are no gains. And this past year, the HAC, for the fiscal year 2018, it was the 4th year of the HAC program. So there are, as far as measures and weights go, there are 2 domains within the HAC program that will determine the overall HAC score. The first is the Patient Safety and Adverse Events Composite, which is also referred as the recalibrated PSI 90 composite. And this domain consists of 10 patient safety indicator measures and carries a 15% weight of the total HAC score. And for domain 2 is comprised of the 5 CDC NHSN measures, and those are such as, CLABSI, MSRA, and CDI, and holds an 85% weight of the total HAC score. Now, as far as calculating the HAC score, there were some recent changes to this particular HAC program compared to prior years. So beginning with the fiscal year 2018, which was the most recent HAC program year, CMS adopted a Winsorized Z-score methodology, and this, like I said, as I mentioned, this has replaced the previous scoring method, which relied on a decile-based scoring system, the previous model assigned HAC scores between 1 and 10. So very briefly, Winsorizing it's a process in which extremely high and extremely low values are renormalized to reduce the impact of those outliers at the 95th and 5th percentile. So a Z-score represents a hospital's distance from the national mean for each measure in units of standard deviations. And what Winsorizing does, it improves precision and leads to fewer ties in total HAC scores, which better distinguishes hospital performance. So as you may recall, the previous HAC scores ranged between 1 and 10, with many hospitals often had ties within their HAC score. But what Winsorizing does, is it makes the scoring system more precise, which separates hospital performance by leading to less ties. And finally, just like previous years, lower HAC scores indicates better performance. So what this slide does is it presents a simple example of what Winsorizing does. So in this graph, we can see that hospital A's SSI measure result was 2.795. And since that measure result was higher than the overall 95th percentile of 2.353, what Winsorizing does, it now assigns hospital A's Winsorized SSI measure result to equal that of the 95th percentile, which is 2.353. So once again, using this particular method reduces the impact of outlier results or hospitals with measures with anomalous scores. So calculating your HAC score for fiscal year 2018 and beyond, a hospital must receive a score in at least one of the two domains to receive a total HAC score. So if a hospital only has a score in one of the domains, the total HAC score is based entirely on that domain score. For domain 1, the hospital must have at least 3 eligible discharges and at least one of the recalibrated PSI 90 measures and have at least 12 months of data. In order to receive a score for domain 2, the hospital must have a standardized infection ratio, or SIR, calculated for at least one of the HAI/CDC measures. So this table represents some scenarios that a hospital might have and how each scenario can affect the total HAC calculation and score. So as far as penalties go, for the last year of the HAC program, which was the fiscal year 2018, the VBP and RRP penalties are taken first and then applied after these other program adjustments are made. And hospitals with a total HAC score of greater than or equal to 0.3687 are subject to a penalty. So once again, obviously the lower the HAC score indicates better hospital performance. HAC program performance scores are publicly reported and displayed on CMS's Hospital Compare website, which is updated for these particular programs every December. So the data that is available for public display for healthcare consumers on Hospital Compare are the recalibrated PSI 90 score, the 5 HAI scores, both domain scores, the total HAC score, and whether or not a particular hospital was subject to a payment reduction under the HAC program. So once again, we'll kind of go over some of the performance for each of the 3 states in the Lake Superior Quality Innovation Network region. And for these next 3 slides, we will show how the HAC program performance for all eligible hospitals in each of the 3 states for the most recent year, which was fiscal year 2018. Remember that the lower HAC scores indicate better performance, and based on the new Winds Rising scoring system, the HAC scores range for these 3 states from around -2 to +2. So for each of these graphs, the bars in blue represent hospitals that performed better than the payment reduction threshold, and those in gold performed worse. And we also have the blue line also represents the payment threshold at 0.3687. So any hospitals with a score of greater than that blue line are subject to a payment reduction. So for Michigan, 19 out of the 105, or around 18% of eligible hospitals, were subject to a payment reduction. In Minnesota, 8 of the 60, or around 13%, were subject. And then in Wisconsin, 13 out of 66, or around 20%, were subject to a payment reduction. So really across the region, a vast majority of the eligible hospitals for the HAC program performed well and were not subject to a payment reduction. So keep up the good work. Just some quick updates from the most previous IPPS final rule, which was once again released in August of 2017. Beginning in 2020, the HAC program will return to the 24-month data collection period. And much like the readmissions reduction program, the extraordinary circumstances exception policy was updated, and those changes to the HAC program do mirror those that were made for the readmission reductions program. So I don't think we need to go over that. And finally, there were no new measures introduced for future years. CMS they tend to use the release of the final rule to introduce new measures for future program years. What they did not do, they did not officially introduce anything for the HAC program. And while that being said, while they didn't officially introduce any new measures, they did mention a handful of areas of focus that could lead to new measures for the program in future years. And some of the new measures that are currently being considered by CMS are the falls with injury, the adverse drug events, glycemic events, and ventilator-associated events. CMS is also looking at including the social risk factors to their risk adjustment methodology of the HAC measures, and they're basing this upon patient demographics such as dual eligibility, once again, it's patients that qualify for Medicare and Medicaid services, race, residence, and disabilities. In regards to the HAC program, some improvement strategies include the proper decolonization of patients, and this has been found to outperform patient isolation, especially with certain hospital-acquired conditions such as MRSA. Deploying an effective antimicrobial or antibiotic stewardship program can help reduce healthcare-associated infections such as CDI or C. diff. Environmental cleaning and disinfecting of hard surfaces in hospital rooms, as well as hand hygiene practices, and really deploying a multifaceted approach to preventing infection is really critical to reduce the risk of HAIs. Also, once again, looking at your data, it can help you target improvement opportunities, and this is, CMS provides hospital-specific HAC reports every year, just like they do with the readmissions reduction program. And these reports can help you understand which measures and domains are the most problematic and adversely affecting your total HAC score. And finally, since the information CMS uses to determine HAC scores is through Medicare claims data, it's important that your coding process is diligent to ensure that HAC documentation is accurately reported so that your hospital is not unfairly penalized. So kind of wrapping things up, we do have some great resources for each of the 3 programs that we discussed today. And as Sarah had mentioned, there are a fact sheet for each of the 3 incentive programs that is located on our Lake Superior Quality Innovation Network website. And like she had mentioned before, these are really great, easy to use resources that provide all the important information for each of the programs, and that is linked up in the upper right-hand corner. And then on these next 2 pages, we have provided some quality improvement resources for each of the 3 programs. And finally, there are some general inpatient quality reporting links and contact information to QualityNet. So with that, that wraps up our portion of the presentation. With that, we would like to open it up to question and answer session or our comment session. So operator, if you could open up the lines for some Q&A.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key on your telephone keypad. We're waiting for callers to join the queue.
Okay, thank you. And we also did want to mention that is the evaluation available to be filled out at this time?
Hi, Ross. This is Holly. We have a couple of questions that came through chat. We did have one from Mary Newman. She asked, when will the excess readmission ratio start to be applied?
When will the excess readmission ratio start to be applied?
Yeah.
Yeah, so this is Sarah, and I think that when that question came in, it was when you were starting to talk about the changes that will take effect in fiscal year 2019. So I'm wondering if it might be related to the peer group.
Oh, if it is related to the peer group, it is the fiscal year 2019. So it is the upcoming program year. So that would be calendar year 2018.
And so, Mary, if I misinterpreted that question, please feel free to jump in on the line or to clarify in chat if you were asking about something different. But I was kind of watching when that came in, and I think that maybe that was what the question was about. There was one just after that asked about when we'll find out where hospitals land in the tier groups, and I did attempt to answer that in chat. So, as just in case you weren't able to see that information is scheduled to come out with the hospital-specific reports that will be released in first quarter of 2018.
Yes, thank you, Sarah, for answering those questions. And if anyone feels that we have not answered the right question or properly answered the question, please feel free to reach out to us with our contact information, which is actually available on the next slide. And we can do our best to answer your question more fully.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key on your telephone keypad.
So we had lots of questions about the slides, and that Holly has indicated that those will be sent out via email to those folks who participated today. We apologize that we didn't have them available for you ahead of time. But the slides as well as the recording will be posted on our Lake Superior Quinn YouTube channel for review. And the slides will be sent out via email.
We did have a question come in from Lydia Edwards. Please go ahead.
Hi. We're trying to determine if there is a cutoff date for submission for extenuating circumstances for exception.
So
Yeah. So I saw your question there in the chat and was hoping that you would speak up to say what, maybe a little more specific what you were looking for. So if you're looking for calendar year 2017?
That's correct.
So, Rob, correct me if I'm wrong, and we can clarify this and make sure that we get back to you appropriately. But my understanding is that any request form needs to be submitted within 90 days of the natural disaster or other extraordinary circumstance. So if something happened within the last 90 days that you would view as an extraordinary circumstance, then you would need to complete that form and submit it in order to have that be considered. Submitting the form doesn't guarantee that it will be accepted, but it is required in order for that to happen.
Okay. I think that answers the question then. Thank you very much.
Thank you.
Is that your understanding, Ron?
Yes, yeah.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. We're waiting for callers to join the queue. There are no further questions at this time.
Thanks. Holly, did we miss anything in chat?
No, it looks like we've got everything covered. Thank you, Sarah and Rob.
There was a question of whether or not the Lake Superior Quality Innovation Network was involved in any specific collaborative aimed at C. difficile infection or any of the other CDC's. I'm sorry, I'm not really familiar with CDC's Strive project. And they were interested in if Wisconsin or Minnesota have any current collaboratives working on C. diff.
So I can speak to Minnesota quickly if you'd like, Ross, and then maybe you can speak to anything you know about in Wisconsin. So as many of you may be aware, CMS made a shift in funding in the last couple of years to move what had previously been funding to the Quality Innovation Networks related to healthcare-associated infections, including C. difficile, and moved that under the Hospital Improvement and Innovation Network funding. So the HINs are now covering a lot of the HAI work. In Minnesota, we work very collaboratively with our Hospital Improvement Innovation Network that's located within our state. We do have a few hospitals that are members of different HINs, but the majority of them are part of the Minnesota Hospital Association HIN. And both the Minnesota Hospital Association, Stratus Health, the Minnesota Department of Health, the Minnesota chapter of APIC, we are all members of what's called the Collaborative HAI Network, and so we work together across care settings to try to improve both antibiotic stewardship as well as reduce the incidence of healthcare-associated infections. So if you're interested in learning more about that collaborative, I'll put the web address in the chat box for folks to be able to check that out. And then we do have resources on staff to address C. difficile at Stratus Health, but we would really encourage you to reach out to the HIN as they are more directly impacting that. In addition, I would just mention that all three of our states, Minnesota, Wisconsin, and Michigan, outside of the hospital setting, do have initiatives around reducing C. difficile in the nursing home setting. So if you are part of a health system that has long-term care facilities and are looking at trying to reduce C. difficile across the board, that would be an interesting opportunity for you to learn about.
And yes, sir, that is what you just explained is also the same situation here in Wisconsin as that work has shifted from our particular organization to really collaborating with the Hospital Association through the HIN contract.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key.
We also just want to remind everyone as we're taking questions and getting ready to wrap up that the evaluation can be found in the right-hand side of your screen. If you are not seeing it, you'll want to click on the little down arrow that's next to the term polling, and then you'll see the evaluation come up. There are just a few questions there. We really greatly appreciate your input to help inform upcoming webinars as we look forward into 2018 to see what we can do to assist you all in your work.
There are no further questions at this time.
Well, So I think that's quite all right, and I think we could kind of wrap things up. So once again, we do appreciate everyone attending, and we'd like to once again stress that the evaluation, that you take the time to fill out that evaluation, and your feedback is extremely important. So since there are no other questions, I guess we can conclude today's educational session. The recording for this presentation will be available in about 2 weeks on the Lake Superior Quality Innovation Network YouTube page, and that is located at www.youtube.com/user/LSQIN. And within that YouTube video, there will also be a link that will have these slides for today's presentation. And one final reminder to complete the evaluation if you have not already, and it really provides us with information that helps us continue to make these quality events. So thank you for your time today, and have a great holiday season.
Thanks, everyone.
Ladies and gentlemen, this concludes your conference call. You may disconnect at this time.